And so specifically, we're going to go over some OB coding, both for outpatient and inpatient. And then we are going to have some dedicated time to kind of go over some of the new OB patient education that we have here at the office. So I'll jump right in. So overview for OB coding, it's kind of different, a little different than how we code for adult and peds visits, because insurance tends to group services together for pretty much antepartum delivery and postpartum care. And so what that means is, depending on what insurance the patient has, and by that I mean either private insurance versus a Medicaid product, they are going to have their coding and billing done kind of usually grouped together in some fashion. And then it also designates how many visits kind of fall into each of those categories. So we're going to go through some of the details, but in general, antepartum care is going to include that initial prenatal history and exam, all of the follow-up visits, anything you're doing as far as like weight and blood pressure and fetal heart tones, the urine dips that we do, and then their definition of like kind of how many visits is typically that monthly visit up till 28 weeks, every 2 weeks, then up to 36 weeks, and weekly visits until delivery, which is pretty much what we follow here at the office. But, and then delivery services include that admission to the hospital, management of what they would term an uncomplicated labor, and we'll talk about there's some designations for other complications, and then either a C-section or vaginal delivery. They do lump in episiotomy and any repair or any laceration and repair as part of the services under delivery. And then postpartum care includes visits that are done there in the hospital, and then what they initially, insurance had been covering just a 6-week follow-up, but now with the 2 follow-up visits that we offer, like Medicaid, for instance, we'll talk about this later, offers to cover 2 postpartum visits. So we end up billing those 3 and 6-week visits separately as part of the postpartum care. So I'm going to click on. And then we'll talk a little bit more about what the global OB package looks like for private insurance and what that kind of includes, because Medicaid and private insurance are really a little bit different. So when we first diagnose a pregnancy, though, oftentimes we are not seeing that patient as a dedicated OB patient at that visit, and we are confirming the pregnancy by a urine dip or an HCG, and they're usually here for another reason. Now, sometimes they're coming in because they feel like they have missed their period and they're wondering if they're pregnant, that kind of thing. But regardless, we would never bill that very first kind of diagnosis as part of their OB care. That would be an E&M code like we would bill any other office visit. One of the ways to designate that we were seeing them for a positive pregnancy test is to use the ICD-9 or ICD-10 code Z32.01, which again, I'll be honest, haven't used before, but this was in some of my reading I was doing, that they say if you use that, that's just kind of designating that encounter was because the patient had a positive pregnancy test, and it can be one of your diagnosis codes for why you saw her that day. Okay. So when we start to really dissect what we need to code for when we see a pregnant patient, you know, I think all too often we are just listing the term pregnancy on a super bill, and I am guilty of that too. So I don't want to say that I've been practicing as I preach today, but I'm going to move toward that. But one of the things that we can do to help both our coders and billers and kind of just overall getting you know, paid for what we do is designating kind of the encounter specific for that pregnant patient. So the codes are a little confusing because they're just codes, but they have designated the Z34 code as kind of the pregnancy code. So all of our pregnancy codes that just designate general pregnancy start with Z34. And then kind of to decipher it is that first pregnancy, the second digit there after the first digit after the decimal is going to be designated as a 0. So as you can see, those top 4 are all for the normal first pregnancy. And then the 5th digit is always what trimester they're in. Now there's a 0 trimester, which obviously doesn't make any sense, but what it is just unspecified, because you may be seeing someone that we don't actually know dates for. So you may not know their trimester. And so that's a possibility you could designate it as a 0. So for example, a first pregnancy in their 3rd trimester would be a Z34.03. And so I know started to try to do that in my notes, but also using those codes appropriately in my notes, but also using that when I'm writing on my super bill. And once you kind of get the terminology or the little pattern, it's not super hard. One thing I did note in Cerner is that if you type in 2nd pregnancy, because I just wanted to see kind of what it would come up with, it actually lists Z34.9. I asked our coders, they think that's more of just a generic term that we're not sure why Cerner designates that. But if you type the word subsequent pregnancy, then it gives you the Z34.8 codes. So just a little nuance, and again, can help us kind of clarify what's going on. So this is from the Medicaid bulletin on OB coding. If anyone wants to read it, I have it all printed out, but when we're seeing our Medicaid patients, we are kind of allotted so many visits during their pregnancy. And so the way they break it down is that a typical healthy pregnancy should have about 3 visits in the first trimester, 3 visits in the second trimester, and then 8 visits in the third trimester. And so again, that's, depends on a little bit on when they start seeing you, but most of the time that fits fairly well. The way Medicaid likes to be kind of, when bills are submitted, our coders have to associate what trimester they're in. And that's why we'll show you the super bill here in a second. That's why it's really helpful if we're seeing our Medicaid patients that we designate what trimester they're in. Because technically there's the modifier, which some of us are familiar with putting modifiers kind of on our super bill for other things, but there's a modifier that would designate what trimester they're in. And really, we don't need to remember that modifier. We just really need to try to circle what trimester they're in, and that helps the coders then attach that modifier for us. One thing that I learned when reviewing all of this and kind of putting this together is that very first prenatal visit, or what we call the new OB visit, sorry, I'm getting a little of an echo. I'm gonna kind of mute everyone here. That first OB visit is actually should be coded as or billed as an E&M charge. And by that I mean is that what Medicaid has actually designated is that first prenatal visit is a little more involved. You're going to do more of a thorough exam, a more thorough history, and you spend a little more time. We book 40 minutes for those patients. So you can actually submit an E&M code, so like a 99214, for that very first new OB visit versus submitting a first trimester code on our super bill. And that's something that I honestly didn't know. So I will admit that I've not done it. What I did find out though is that on the back end, our coders and billers are kind of helping us with this. They did fully admit that they do not catch this every time because they don't always know that it's that new OB visit, but for the most part, they're trying to catch that. But on our end, if we're able to bill it that way, and we put that Z34 point, and if it's their first, pregnancy, 0.01, because they were in the first trimester a lot of times when we're seeing for that new OB visit. And then that would be your code, and then you'd build it as a 99214, because most of the time you're doing a fairly thorough or thorough evaluation, and the time component, as we know, is going to be part of that 99214 component coming up in January. So for the most part, most of those new OB visits will probably fall into that category. And so I just wanted to bring that up because that's something that I didn't really fully realize until I read the details in here. And, I think our coders help us out a lot and didn't really share that we needed to probably be doing that. So. There will be times, probably a lot of times, when our patients are not just low risk normal pregnancies, right? So there's going to be a lot of times where our patients are coming in for a lot more visits than what's allotted because they've got high risk conditions during the pregnancy. And so if that's the case for our Medicaid patients, we actually can get paid more when we are kind of coding appropriately and making sure that we put the diagnosis that's associated with why they're coming in more frequently. So being aware that if we see someone because they're gestational hypertension, their GDM, they have history of things in previous pregnancies, so you're seeing them more often to kind of monitor for that. Any of those things, we need to make sure that we have that additional diagnosis listed both in our note and on, and on our super bill, because that will get us kind of paid better. And it designates then that we're going to be, it's a high risk pregnancy. And so that's important. We'll look at the super bill here and I'll kind of show you, but that's something that we want to make sure that we are doing. And again, the high risk, you can receive extra prenatal care visits beyond that maximum of 14 if you're using the 009 series codes, which are the high risk codes, and I'll kind of show you that. So I gave you an example down here. If you're seeing a G2P1 at 35 weeks and she's got GDM and gestational hypertension, so it's basically been that you've been seeing her weekly since around 32 weeks, you can code that visit as a Z34.83 because she's a subsequent pregnancy in her 3rd trimester. And then the code for GDM, not that anyone needs to memorize this, and I do not have it memorized, is O24.410, and the gestational hypertension code is O13.9. And again, that just kind of designates that those O codes are kind of what ends up falling out for the high risk. And then when we're circling on the super bill, I'm going to show you this because a lot of people have asked or don't know why it says 7+ visits in the OB area. And it's because for this patient in particular, she has definitely come more than 7 times, and more than 7 times in Medicaid's world, they start paying more after that 7th visit, even though they're they can maximally see them for 14 visits. But there's a magic number for them, because then those visits after that, after the 6th visit, get billed a little differently. But then adding these other codes on, especially if they're now at the max number of visits, is going to get reimbursed better. So just to kind of break it down a little differently, and this is again from the Medicaid booklet, this just kind of shows that very first antepartum visit, or that new OB visit that we see our patients for, can be billed, or should be billed actually, as an E&M 99201 up to 99215. So you've got some range there. Obviously depends on how complicated and new patient versus established patient. Typically they do want us to use a modifier, but I know when I talk to our coders and billers, they said as long as our note has an LMP and an estimated gestational age in the note, because they do have to review our notes, then they're going to be able to attach that modifier appropriately. So the key is just making sure you have included that information, which I hope for the most part in your OB visits you are, but that is important information for them to be able to submit. So the other thing that I learned, again, breaking down what Medicaid does for our patients, is that the visits 2 through 6 are technically coded as a 59425. And again, needing to know what trimester they're in, but they can get that from our note. And then visits 7 and beyond are billed at a 59426. The good thing is that our coders and billers really actually end up tracking those visits for us, because I was worried after kind of re-reviewing this that I would have to know how many visits my patients had. And with different providers seeing patients, that would be almost impossible to know. And they actually keep kind of a card on each of the OBs, and so they keep track of how many times they've been seen. So luckily, we don't absolutely have to know that, but on our super bill, I'll kind of show you. Let me see if there it is. We'll skip through up to this. So on our super bill, you can notice that I kind of put the code. This is like a normal first pregnancy, first trimester patient coming in. Maybe she's coming in for her 16-week visit. So she's in the first trimester, and actually she'd be in the second trimester. So this is the first trimester. Maybe this is not your new OB visit, but right after that, you would designate as a 59425. One thing I did note, and Tina and I was going to talk to her, but that our 7+ visits should be a 59426. So I happened to catch that typo on here. So we'll just, our billers and coders said they usually end up catching it, but we'll end up changing that sheet just to reflect that. But that's what the different trimesters mean, is the first, second, and third trimester and the 7+ visits. Those are really Medicaid coding. And so when you're seeing your patients, being familiar whether they're a Medicaid patient or a private insurance patient is important, because that is how we're going to circle appropriately as far as what the codes are. But like I just mentioned, if you're going to see a new OB, you're probably going to bill like a 99214 or possibly a 99204, depending on her risk factors and kind of the medical decision making, et cetera, going into that. And then postpartum care we'll talk on here in just a little bit. And then I'm going to jump into kind of what global OB care means for our private insurance patients. So let me go back. So for our routine outpatient OB coding for private insurance, it's done a little bit differently. So what happens is the billing is actually done at the end of the pregnancy. So after the delivery, actually. And so the whole charges for antepartum care, delivery care, and postpartum care are kind of lumped into one big sum. And that's why cost containment, and I talked with some of the group yesterday about inductions and the cost of each agent that we use for inductions. That's why it's somewhat important to the hospital to use things that are a little less costly, because they're only going to get reimbursed a certain sum of money for the whole OB package, and that could mean a routine newborn or a routine delivery, or someone that's got some higher risk, and we'll talk about how you can designate some of that. But that global OB package is actually going to include that initial OB visit. It's going to include monthly visits up to 28 weeks, the biweekly visits to 36 weeks, and then weekly visits until delivery. And then it's also going to include that delivery. And then actually the postpartum is included in that too. And I don't know why I didn't list that on there, but the postpartum is part of that as well. And so what we're going to do for our private insurance patients is pretty much they're going to get charged a one-time copayment usually at the beginning of the pregnancy, and then they really won't get billed again until after the delivery. And so, you know, if they have questions about that, at least I wanted you guys familiar with how that happens. And they will then, they won't see any bills coming through. And so sometimes that makes them a bit nervous about how much is this all going to cost? But that's kind of how the global package is billed. If there is a doctor, though, that does, so if the services we provide are the antepartum services, and then the patient actually goes to our hospital and either because of a planned C-section or an emergency C-section, obviously has a C-section by a physician outside of our office, which would be our OB care docs, then that global package then actually has to get broken into components. And so that's where it gets really confusing to some extent, and that's really not on our side to figure out, except that it is in our purview to basically let our coders and billers know. And so I always make sure that I say, Dr. Landwehr performed C-section, you know, so that is going to be billed separately. We're going to bill for the antepartum care now. And then usually we're going to also bill for the postpartum care that's received in the outpatient sense. Most of the C-section patients are still rounded on by the OB docs, as well as you guys on the postpartum, you know, floor. And so, but those charges are usually kind of put into what the OB docs are doing for their kind of billing and coding. So, so it gets a little confusing, and I would not say I'm an expert on this, but from what I understand when I've talked to our coders and billers, they are kind of aware that they've got to watch for that, but they definitely like the heads up to know, hey, you know, we didn't do the delivery. And that could also happen if an OB does the vaginal delivery, for instance, there's a precipitous delivery or there's, you know, a delivery one of us can't make it to, that also will be billed out separately. So that just wanted to let you know. And then the things the global package does not include, it doesn't include that like initial visit when you diagnose a pregnancy. I mentioned that at the very beginning. If there was an amnio, if there was a version, additional E&M services for like unrelated reasons, like they came in for their asthma or UTI, or if they had greater frequency of visits. So based on what their recommendations of visits, if you go past that, then you need to make sure you have the high risk code listed on that, because what happens is the coders and billers then recognize you've kind of gone over your amount, and then they start actually billing those as E&M charges. And so again, it's almost impossible for us on our end to track that. And so we are blessed to have people that are kind of watching that. But just so you guys understand how that works, those charges end up kind of dropping out as like a 99213 or 214 if it's not going to be included in the global OB package. And we talked about the super bill. And then I wanted to just touch base on outpatient NST billing too. There's a separate CPT code for them, and that's on our super bill, the 59025. The biggest thing is anytime we're billing or coding for an NST, we need to make sure we have the why, and it can't just be pregnancy, because we shouldn't just be doing an NST because they're pregnant. We need to have a diagnosis code. So making sure that your NST super bill has that diagnosis code is really helpful. And then when you're documenting NSTs, I've told a number of you that we really must have a separate, it's best to have a separate NST note because it's really billed as a separate procedure. And so making sure that you have, you know, how far along the patient is, why you did the procedure, what the NST showed, so your baseline fetal heart tones, any XLs, I mean, hopefully XLs that meet the guidelines, any decels, any contractions, and then your overall assessment, was this reactive or non-reactive, and then what's your plan? Usually that plan is follow up in 4 days for a repeat NST, or it's sent to triage for further monitoring, that kind of thing. So, and I said here, please steal my auto text if you'd like, because I've got a .NST, so if anyone wants that. And now jumping to the delivery coding, this is a little bit bigger kind of a group of codes, and because you guys don't do a ton of inpatient or really any inpatient coding, I don't want to do a lot of deep dive into this because I don't feel like it's great to memorize. But what I wanted you guys to see is that there are quite a few kind of breakout codes for doing the delivery all by itself or doing the delivery as part of the whole package. So that 59400 is one of the more common ones that like we would submit because our clinic provided the antepartum care, we did the vaginal delivery, and then we provided the postpartum care. So that's that global fee that oftentimes those of us that are attending your deliveries, that's how we'll submit that. Now, if we just did the vaginal delivery, that would be something like maybe the OB's coming in to just deliver, or maybe I was on the floor and they couldn't make it and I just did a vaginal delivery. I could submit just a delivery only fee. And then they've also broken it into a delivery plus postpartum care. So that makes sense when someone's maybe more of a hospitalist, OB hospitalist, where they're delivering and doing the postpartum care, but they don't do any of the antepartum care. And then there are some other things. Sometimes we only make it for the placenta. And so if that's the case, you can still bill for the delivery of the placenta. And then once a global fee's kind of been broken up, then the other fees get submitted. And so that antepartum care visits 4 through 6 can be billed separately, and then 7+. So again, there's that magic 7, but 7 or more visits can get billed at that 59426. And so, and then the postpartum care, which is actually listed on our super bill, that can be separately billed, but it's only if we're doing that like as its own thing. So technically, when you guys are seeing a postpartum patient and you write postpartum care or postpartum patient, as their diagnosis, and then you circle the 59430 because it says postpartum on there, a lot of times, honestly, those aren't being billed separately as a postpartum visit because they're under the umbrella of global care or Medicaid's umbrella, which includes 2 postpartum visits. So just wanted you to know that was kind of happening. And then C-section also, you can be kind of broken out into components. And then there's actually a whole different set of codes for patients that have had basically vaginal deliveries and then had or had a vaginal delivery after a C-section. So that kind of changes the codes too. So it's a little bit of everything. And then, like I mentioned earlier, postpartum care billing, for Medicaid, they will pay for 2 postpartum visits. So right now our coders and billers are really submitting those as the 3 and 6 week postpartum visits. Previously to that change that ACOG had, we were actually submitting at least one of those codes as an in-house postpartum care visit, and then one for that 6 week postpartum visit. But now, to try to make sure we're recouping everything we do in the outpatient world, they've switched gears and kind of are submitting those 2. I'm not sure what happens if patients are actually missing those visits, if they go back and try to submit what was happening at the hospital. I didn't ask that question, but. And then the big thing here I wanted to point out, because this happens often, is we have to bring in our patients for an earlier checkup because they've got a hypertensive disorder in the pregnancy. And so postpartum, we're following that up. And those visits, if we're bringing them in for something other than what we would consider routine postpartum care, really need to be billed as an E&M code. So a 99213 or 99214, and just make sure you have the correct diagnosis, that they had gestational hypertension or that they, had preeclampsia or those kind of things. And so, again, probably not something I'm doing routinely enough to really think that, I know that if I've kind of used up my 2 postpartum visits, I need to bill differently, but I probably wasn't billing. I was probably billing them and then doing the E&M later. So, so if you get those patients that you're seeing for high risk stuff, make sure you're actually coding for that risk condition, and then your postpartum visits will come later. And then your private insurance, the global package covers routine E&M services provided within 6 weeks of delivery. So again, that would be hypertensive disorders and those kind of things. So they actually cover that all under the one umbrella is what I was told. So if for some reason you as a physician is the only one doing the postpartum care and you didn't actually deliver her, or no one in the clinic delivered, then we would actually submit just a postpartum only. But that actually doesn't happen hardly at all around here. So, but that could happen out in private practice. So, and then any problems or complications that need followed up, we should still, like we did above, do it as an E&M code. And then you could still list postpartum as one of the conditions, but then gestational hypertension or preeclampsia is one of the other conditions that you're doing the more frequent visits for. So I'm gonna stop for a second because I've got a couple other slides on some other things. Oh, wait, one more slide and then I'll stop. So billing for conditions not related to the pregnancy. Do remember that if you see a patient during pregnancy for any non-pregnancy related condition like bronchitis, pneumonia, UTI, that you really want to bill like a routine office visit for those, so they don't really get tucked into their pregnancy billing. So if you have questions on that, let me know. So I'm going to stop for a second and see if anyone has questions. Any questions? I don't see any chat. Any comments? I know Tina's on here. Anything anyone has struggled with, or does that, hopefully it helps a little bit understand what we're supposed to circle.
Dr. Schreiner, it's Kristen here. So I think maybe this is looking forward too much. In the future, we're not gonna have the super bill. Is that gonna be intuitive, I guess, within the OB experience of how to click and modify?
I'm not 100% sure. I think what will be nicer is that if you designate codes, they're going to pull over. So if you have a problem on the problem list, you're not going to have to transfer that, to your super bill, which is nice. But I don't know how it's going to look for like OB visits, as far as, you know, if it's going to be designated like this is trimesters and kind of break it down. I haven't seen the demo of it for the OB stuff. So, and I have heard, Tina may have more comments on that, but I've heard that they're putting that off a little bit. So we were told October, but that may be more into the first of next year. So, so I haven't heard any recent updates, but that's what I understand now.
Okay, thank you.
Other questions? Okay, we're gonna finish here so we can get into our small groups if people are available. So I wanted to just mention to everyone that we are starting centering pregnancy again. So I'm very excited. Tiffany and Heather and I are gonna be kind of the facilitators to start off with, and then we'll hopefully be able to fold in some residents that have interest. But we're going to start next week with our first group, and it's going to be a virtual group. So obviously right in the time of COVID, we can't group together, you know, 8 to 10 individuals in the large conference room. And so we are going to be doing virtual groups via Zoom. And so I've asked Tiffany to call all of our patients under 28 weeks to gain interest. And it looks like we have actually 14 women interested, which is awesome. So, and we actually asked them whether they were more interested in an afternoon or a morning group meeting. And so we had about half and half. So my goal is that we actually may be able to offer both an afternoon and a morning group. You know, these groups are going to be a little different than what I call old centering, in the sense that there's not going to be any actual assessment happening at the group. Because we don't really have a way for our patients to reliably have their blood pressures checked and get weights at home. That's a separate thing I'm going to ask for in a grant later to see if we can get all of our OB patients blood pressure cuffs and scales. But we're going to kind of try this. The goal is to have a group meet for about 45 minutes, maybe up to an hour, and, you know, have certain designated topics. We're going to let you guys know if your patients are involved in centering. This will not be billed separately from their OB visits, and they will still remain your patients and come to your visits. So it's really just to enhance their OB education and not really replace any routine OB visits. So hopefully it's a good enhancement for them. And then as we get more comfortable with it, we may be able to do some assessment in breakout rooms on Zoom, but we just don't have the capability yet. So we're excited. And then we're going to be breaking into group. I know it's a little past the time I'd hope, but that's okay. We can kind of go through it. But we're going to be showcasing our 3 separate trimester booklets that are for our OB patient ed now. Huge thanks to Heather for formatting these and revising content multiple times, and really pushing our marketing folks to get these done. So it's been a long time coming. And so those of you that are on campus and able to get to the rooms, we're going to have the 3rd years meet with Heather in the large conference room, 2nd years with Tiffany in the middle conference room or conference room 2, and then I'll meet with the interns in conference room 3. If you're not here on campus, we do have for everyone a red folder that has the patient education trimesters in them and an updated FMRC OB guidelines. So come see me and we'll get you those. So don't want you to be left out. So awesome. Any last little questions? Okay, we'll move to the rooms.